Welcome to this explainer. Today, we're tackling a really fascinating clinical mystery, the pleural effusion. You know, the human body is an incredible, finely tuned machine. But what actually happens when the plumbing inside a tiny, almost invisible space suddenly overflows? Well, it sets off a whole cascade of clues that we as diagnosticians have to piece together.
To figure out this mystery, we've got to start at the scene of the crime. A pleural effusion is, simply put, an excess accumulation of fluid in the pleural space. Under normal conditions, this space just holds a very thin layer of fluid. Think of it as a mechanical coupling system between the lung and the chest wall, right? It lets them glide smoothly against each other every single time you breathe. It is a perfect balance of fluid formation and lymphatic removal. But an effusion happens when that drain gets overwhelmed. Basically, when systemic or local disturbances outpace the body's ability to reabsorb that fluid.
So, here's our roadmap for today. We'll start with what a pleural effusion is, spot the physical signs, hit the crucial diagnostic step with the great fluid divide, and then break down those transudates versus exudates.
Part 1. What is pleural effusion? Okay, let's dive right in and look at what the patient actually experiences when this delicate system fails.
Patients with a pleural effusion usually present with dyspnea, shortness of breath, and sometimes pleuritic chest pain. But here's the really wild part. That dyspnea can be disproportionately severe compared to the actual size of the effusion. You might think, hey, a small fluid buildup shouldn't cause much trouble, right? But because this fluid messes directly with that mechanical coupling of the lung we just talked about, even a modest effusion can leave a patient severely breathless.
Moving on to Part 2, spotting the physical signs. Before we even think about looking at a scan, we have to gather our first clues right at the bedside.
When you're examining the patient's chest over the area of the fluid, you're looking for 4 classic signs. First off, you'll see reduced chest wall movement. Second, when you percuss or tap the chest, you're going to hear this very distinct stony dullness. Third, when you listen with your stethoscope, breath sounds are going to be decreased or just completely absent. And finally, when the patient speaks, you'll feel reduced tactile vocal fremitus and diminished vocal resonance. Essentially, this wall of fluid is literally dampening the body's normal acoustics.
But you know, physical signs are really just the beginning. Before we ever introduce a needle, we need definitive visual proof. We'll use chest imaging like lateral decubitus X-rays to catch free-flowing fluid. But point-of-care ultrasound and CT scans, those are absolute game changers here. They let us evaluate the exact extent of the fluid, spot complex pockets called loculations, and, most importantly, they give us a map to guide safe drainage.
So we can see the fluid. We know it's there. But how do we actually track down the cause? The answer is a diagnostic thoracentesis. We have to go in, aspirate some of that fluid, and interrogate it to see exactly what it's made of.
Which brings us to Part 3, the great fluid divide. This right here is the absolute turning point in diagnosing any unexplained effusion.
Our main goal is to classify the fluid into one of 2 buckets, a transudate or an exudate. Think of the pleural capillary barrier like a coffee filter. In a transudate, the filter, the capillary barrier, is totally intact. The fluid is just being pushed through because of systemic pressure alteration somewhere else in the body. An exudate, on the other hand, means the filter itself is damaged. There's local inflammation or infection causing increased vascular permeability. The barrier is leaky.
Now, to objectively figure out if a fluid is an exudate, we use a very specific set of rules called Light's criteria. We're looking at 3 exact markers. Number 1, the pleural fluid protein to serum protein ratio is greater than 0.5. Number 2, the pleural fluid LDH to serum LDH ratio is greater than 0.6. And number 3, the pleural fluid LDH is more than 2/3 the upper limit of normal for serum. If the fluid meets any single one of these 3 criteria, just one, it's officially an exudate. If it meets none, you've got a transudate.
But watch out, because biology absolutely loves throwing us a curveball. Beware the pseudo-exudate. If your patient has heart failure and they're taking diuretics, that medication can actually concentrate a transudative fluid. So when we test it, it might falsely satisfy Light's criteria and look exactly like an exudate. When that happens, we have to look at the serum to pleural fluid protein or albumin gradients to properly reclassify that fluid back to a transudate.
All right, Part 4, transudates the systemic failures. Let's see how this builds out our differential diagnosis. Remember, the barrier is intact, but the systemic pressures are failing.
The absolute heavyweight leading cause here is heart failure, specifically left ventricular dysfunction. Elevated pressures are just driving excess fluid right into the lung interstitium and across the pleura.
In fact, a pleural fluid NT-proBNP level over 1500 is highly suggestive of a cardiogenic cause. Another wild one is hepatic hydrothorax. In about 5% of patients with cirrhosis and ascites, fluid literally migrates from the abdomen directly into the pleural space, usually on the right side, through microscopic holes in the diaphragm. We also see transudate in systemic conditions like nephrotic syndrome and in folks undergoing peritoneal dialysis.
Part 5. Exudates, the local culprits. When Light's criteria tells us that capillary barrier is actively leaking, we have to start hunting locally.
The most common exudates by far are parapneumonic effusions and MPIMA. We see these in up to half of all patients with bacterial pneumonia. They might start out reactive and totally sterile, but if they get infected, they evolve into an MPIMA, which is frankly purulent fluid. And this is where your lab analysis becomes absolutely critical. If the fluid's pH drops below 7.20 or the glucose falls below 3.3 millimoles per liter, that is a massive red flag. It means an advanced intervention, like a tube thoracostomy, is required immediately to drain it.
Another major local cause for a leaky exudate is malignancy. Cancer cells can compromise the pleural space, which means you'll need fluid cytology or image-guided biopsies for a firm diagnosis. But when we look at the breakdown of exactly which cancers cause this,
Get this, 75%. Just 3 types of cancer, lung carcinoma, breast carcinoma, and lymphoma, account for roughly 75% of all malignant effusions. Statistically speaking, if you are looking at a malignant effusion, the source is overwhelmingly likely to be one of those 3.
But I really want to highlight a major diagnostic pitfall here. Pulmonary embolism is the most frequently overlooked cause of an exudative pleural effusion. If you have a patient sitting right in front of you with unexplained dyspnea, pleuritic pain, and an exudative effusion, you must strongly consider a PE. It is a dangerous local culprit that often hides completely in plain sight.
Just to round out the local culprits, we have some very specific markers for distinct conditions. An ADA level over 40, that points heavily to tuberculous pleuritis. If there's a disruption of the thoracic duct leaking this milky fluid, a triglyceride level over 1.2 confirms a chylothorax. And if the fluid is frankly bloody, check the hematocrit. If it exceeds 50% of the peripheral blood hematocrit, you've confirmed a hemothorax.
Which brings us to our final thought. We started out by defining the pleural space as this super thin, mechanical coupling system. But if a disruption right here can point us to everything from a failing left ventricle and a cirrhotic liver to hidden lymphomas and stealthy pulmonary embolisms, what does a flooded pleural space truly reveal about the broader health of our entire body? It's not just a localized pocket of fluid, is it? It's a brilliant, urgent alarm bell for the whole system, provided we know exactly how to read the clues. Thank you so much for joining me for this explainer, and keep asking those great diagnostic questions.